Good morning, good afternoon, good evening. I'm delighted to co-chair this session on the Decade of Healthy Aging: Data, Research, Evidence, and Knowledge. My name is Vivian Welch. I'm the Editor-in-Chief and the CEO of the Campbell Collaboration, which is dedicated to producing and encouraging the uptake of systematic reviews in social sciences and social policy. I'm delighted to introduce the four speakers for this session. The first speaker is Dr. Jyotiswar Amuthavali Thiagarajan, and he will be speaking about measuring, monitoring, and evaluating the impact of the Decade of Healthy Aging. Dr. Jyotiswaran is a technical officer in epidemiology at the Aging and Health Unit of the World Health Organization.
Good morning, good afternoon, good evening, wherever you are on the place. For the next 5 minutes, I'm going to talk about the measuring, monitoring, and evaluating the UN Decade of Healthy Aging, which is a lead WHO program for supporting healthy aging in countries. So as we all know, population is aging worldwide, and countries are mostly low and middle income countries are experiencing rapid demographic and health transition. And this recent shift in demographic and health will impact almost all aspects of the society. In recent years, the world is also confronted with multiple global challenges such as pandemic, climate change, war, inequalities. As a result, countries are falling behind on their sustainable development goals, which ultimately impacts the health and well-being of older persons, their families, communities in which they live. UN Decade of Healthy Aging 2021 to 2030 is a global collaboration aligned with the 10 years of Sustainable Development Goals that brings together governments, civil societies, international agencies, professionals, academia, the media, and private sector to improve the lives of older people, their families, and communities in which they live. Its vision is a world in which all people can live long and healthy life. On 3rd of August 2020, the UN Decade of Healthy Aging was first endorsed by 194 countries in the World Health Assembly, and then it was subsequently forwarded to endorsement in the UN General Assembly in 2020. And this has formally gone through 2 assemblies, and all the member states have agreed to the new global actions and strategies that WHO has proposed. So the UN Decade of Healthy Aging has 4 main action areas. The first one is changing how we think and feel and act towards age and aging. Second action area is to ensure the communities foster the abilities of older people. And the third action area is delivering person-centered integrated care and primary healthcare service responsive to older people. The fourth action area is providing access to long-term care for older people who need it. In order for countries to implement, WHO also proposed 4 main enablers that includes listening to diverse voices and enabling meaningful engagement with older persons and communities. Second, nurturing leadership and capacity building. Third is connecting various stakeholders around the world. And last is strengthening data research and innovations. Aligned to the global strategy that WHO has provided, many regions and countries have started to develop a regional strategy for healthy aging and also national strategy and national program for healthy aging. As you can see on the document on the left-hand side, you have a global strategy on healthy aging that was formally endorsed in the World Health Assembly and UN General Assembly. And then based on the global strategy, West and Pacific region has developed a regional Pacific strategy for healthy aging. And based on the regional Pacific strategies, countries are now in that region is developing country-specific strategy for promoting healthy aging. Although countries have started to work on the country-specific strategies, more advice and guidance are needed for countries in order to monitor the regional level strategy and country level strategy on how countries are progressing and making impact on lives of older people. In order for WHO to support countries on tracking the progress and measure the impact of the UN Decade of Healthy Aging, several technical tools and products are needed. First is, currently there is no monitoring and evaluation framework for countries to use for monitoring the national level or subnational level programs on healthy aging. Second, the indicators that we have largely around the world we focused on chronic diseases, but for older people, health is not determined only by disease. Health is more about older people's abilities to build and maintain their functional ability that enables well-being in older age. So the indicators that we have at the moment may be largely focused on diseases. We want to shift this paradigm and help countries to monitor not just disease, but also the older people's engagement and participation in the society. So we need a new set of indicators that support countries to monitor the national and subnational program. Third, healthy aging is relatively a new concept. WHO introduced this new healthy aging concept and introduced a public health framework in the year 2015. More evidence is needed in terms of how to measure them. What kind of instrument country can use to collect data on healthy aging in a clinical setting and also in a population setting is currently remains unclear. So we have a plan also to produce evidence-based guidance on instruments for collecting data on healthy aging and also other relevant outcomes that are critical for the UN Decade of Healthy Aging monitoring. Last, guidance on aging surveys, data analysis and reporting is also required. A lot of countries do not have a regular and routine national survey on aging, and many countries are planning to initiate new national surveys on aging. So we would like to provide some guidance on how to design and plan a new national surveys on aging, what kind of data should be collected and how the data should be analyzed and reported. At the heart of all the measurement work that we have been thinking, there are three core issues to be addressed. The first one is we want to have an integrated M&E framework, monitoring and evaluation framework that's aligned with the global framework, which is not just a framework that brings together all the relevant relevant indicators together, but it's a framework that also helps country to fix a goal and help country to monitor the achievement towards the goal. Second is in terms of aging, there may be a lot of indicators that country can potentially pull in, but the important question is what set of parsimonious set of indicators that are helpful for monitoring the goal that country wants to progress towards for the UN Decade of Healthy Aging is a key question. So we would need to sort out how those kind of indicators can be used to monitor the goals and actions. Third, the targets and so far in the history of public health, there has been no attempt at a global or national level to set targets for programs on aging. So in moving forward and advancing the measurement work, we also wanted to set some targets and provide some guidance on how to set some realistic target for countries to focus their resources and also their attention towards achieving them in a realistic time frame. So first to come up with a set of global indicators relevant for healthy aging, what WHO has done is that we grouped all the available indicators into different thematic areas. So these thematic areas are leadership and commitment, policies and law, voice and engagement, data, research and innovations, infrastructure, finance, geriatric workforce, information system, enabling environment, healthy aging, and long and healthy lives, cause of mortality, need for care, and well-being. Second, each indicator will have a very clear definition, purpose, method of measurement, calculations, data collection method, data collection frequency, data disaggregation, guidance on interpretation and use of data, also strength and weaknesses of each indicators, and some of the challenges in collecting on a routine basis in a clinical and population setting will also needs to be documented. So once the WHO completes this work with all the information on the metadata, we also plan to have an online indicator toolkit for tracking the outcomes and results in all countries. So this toolkit will also be published very soon with all the information that's shown on the screen. Second, on healthy aging, the WHO provided a new definition, as I mentioned before, in 2015, which has three dimensions. One is intrinsic capacity, second is functional ability, and third is enabling environment. And particularly for intrinsic capacity and functional ability, there has been no recommendation from WHO side on how to measure these two constructs. So in order for us to draft evidence-based recommendations, currently WHO has commissioned 10 systematic reviews, and these systematic reviews are conducted by 10 different teams, academic partners in different parts of the world. And this team will look at the psychometric properties of all the best available tools in geriatrics and aging research that has been validated in the last 50 years. And this tool will be reviewed systematically. Once the psychometric properties such as reliability, validities are documented, WHO will use this to provide recommendations to countries on which tool may be appropriate to collecting data on healthy aging. Second, as I mentioned before, there's a huge data gap. More than 60% of older people live in low and middle income country, where the less than 10% of these countries actually have a national surveys on aging. So this data gap must be addressed if you really want to understand the health and lives of older people in the regions where majority of them are living. So what WHO planning to do is that there is a plan from WHO side to do a World Health Survey in 120 countries starting from next year. And this survey will have an aging module that will be structured around the data that we needed to monitor the UN decade of healthy aging. And we will be working with the technical advisory group to decide on what indicator WHO should prioritize and how do we structure the aging survey that country will be using for data collection starting from next year. In order for us to advance on the indicators and monitoring and evaluation framework and deciding on the survey module, WHO established a technical advisory group, which consists of 20 top experts in the field, representing all 6 regions of WHO. And in collaboration with several other UN agencies, this group will be looking at all the technical work that WHO has planned to do in coming years and coming up with a very clear recommendation and scientifically robust advice that will be given by WHO to countries in coming years. For more information on this group, you can follow the link on the slide. Last, in order for us to address the data gap, WHO also established the aging data portal. This is a web-based platform where all the data available, best data available about aging across the world on different thematic topics are being summarized, and data that we have in this portal are visualized using a best available data visualization tool. And people who wants to download this data, there is an option to export all the data that's available in this platform for different academic purpose. So that's quite feasible, and there is no cost associated for downloading this data. Last, in order to support, as I mentioned, we plan to have a several product release to advance the measurement and monitoring work. First is there is a process that we put in place in order for us to develop a national toolkit for monitoring and evaluation of UN decade of healthy aging, and this will be published in this biennium 2022 and 2023. Second is evidence-based recommendations on measures of healthy aging will also be published in this biennium once the systematic reviews are completed and WHO expert advisory group have drafted the final recommendation. Third, aging survey module for World Health Survey Plus are under development. It will be released next year for countries to use for new national survey or collecting new data at the health facility or a subnational level. Last, online toolkit for tracking the progress on healthy aging is currently under construction. Once the indicators and frameworks are being finalized, this toolkit will be put in for public domain for everyone to use and download information on different indicators that are relevant for healthy aging. So for more information and also to get involved in this work, feel free to email me. Thank you.
The second speaker today is Dr. Christopher Michton. Dr. Michton will be speaking about building an evidence architecture for social isolation and loneliness and identifying research priorities for elder abuse within the decade of healthy aging. Dr. Michton is a technical officer at the World Health Organization. The floor is yours, Dr. Michton.
Hello, everyone. I'll be talking about 2 research and evidence synthesis activities related to the cross-cutting topics of social isolation and loneliness, where I'll be discussing the building of an evidence architecture, and abuse of older people, where I'll be talking about selecting priorities for the field. These are 2 important topics. About 20 or 30% of older people in many countries and regions of the world experience loneliness every year, and it has serious consequences for longevity and for their mental and physical health. And we estimate that about 1 in 6 older people experience abuse every year globally. And again, with many serious consequences for their mortality, for their mental health, for their physical health. And these two topics cut across the 4 action areas of the decade, which are listed here in many different ways, only a few of which I'll mention. One, for instance, is that ageism, action area 1, is a risk factor, an important risk factor for social isolation and loneliness. And ageism, action area 1, is one of the main reasons it appears that the abuse of older people does not get the attention it deserves. Social isolation and loneliness and the abuse of older people have serious consequences for mental and physical health, action area 3. And we know that rates of abuse of older people in long-term care facilities are very high, with some studies suggesting that up to 2 out of 3 staff have report perpetrating abuse. So yeah, these two topics cut across these 4 action areas. I'll start with the building of an evidence architecture for social isolation and loneliness. Why did we think that building an evidence architecture for social isolation and loneliness was important? Really, there's one main reason for this, and that's that most interventions, and this is not only in the area of social isolation and loneliness, but these are social interventions in general, don't work. Most interventions are not evaluated, and most evaluations are not used. As a result, billions of dollars of money from governments and individual donations is wasted on ineffective programs. This is a quote from a paper by Howard White. The link is there. And in this paper, Howard White also talks about the 80% rule. That is, that about 80% of social interventions do not work. Some people dispute that. They think it's 60%, maybe 50%, but still a large proportion of social interventions do not work. So unless we have rigorous evidence proving our interventions work, we should assume they don't. This is a diagram of the evidence architecture, which should try to clarify the concept. Also, this is also from the paper by Howard White. The main purpose of an evidence architecture is to institutionalize the use of evidence in policy and in practice. An evidence architecture is made up of 2 broad components, these 2 multicolored triangles you see here. The first component is the supply component, what is often called the evidence base. And the second component is the demand component. The supply component goes from raw data at the bottom of the triangle or pyramid through primary studies to a variety of evidence synthesis products, such as systematic reviews, databases, evidence maps, and guidelines, right up to checklists. But creating the supply of evidence, an evidence synthesis product, is not enough. You also have to stimulate and channel the demand for evidence. And that's done through the demand component of the evidence architecture. This includes, for example, evidence workshops to engage the community of users, evidence-based budgeting, where money is only allocated to programs supported by evidence. So we have these 2 components. One, the supply of evidence, and the other, which till now has been very often neglected, the stimulation and the channeling of the demand for evidence, teaching people how to use evidence, persuading people that using evidence is a good thing, and so on. Our aim is ultimately to build such an evidence architecture for the field of social isolation and loneliness. And we're hoping to do this in close collaboration with various partners, Campbell collaboration, with whom we've already been collaborating, the Global Initiative on Loneliness and Connection, the EU Commission's Joint Research Center, and a number of other collaborations. Our current and planned activities on the demand side of, the supply side of the evidence architecture are listed here. We're working with the Campbell collaboration with Vivian Welsh, who's actually moderating this session. The Campbell collaboration is doing for WHO 2 evidence and gap maps, one on digital interventions to reduce social isolation and loneliness, and the other on in-person interventions. Another activity we're just starting work on is the development of guidelines. These are official WHO guidelines with recommendations, and these will be based on a number of either existing or new systematic reviews. In the future, we hope to develop some kind of evidence portal, which will bring the results of the evidence and gap maps and the guidelines together and distill them in a way that's easily accessible to policymakers and to decision makers. On the demand side, currently we're in the process of doing what's called an evidence ecosystem assessment, and then further down the line, once the guidelines and the portal are available, we'll be conducting workshops on the use of evidence in this area and maybe other activities as well. This is the almost final draft of the evidence and gap map that the Campbell collaboration have created for us on reducing social isolation and loneliness among older people. This is based on systematic searches and screening of multiple databases and other websites using explicit inclusion and exclusion criteria. Just point out 4 features of this evidence and gap map. Soon it will be available online and you'll be able to explore all its different features. In the rows here, you have different types of interventions. For instance, you have as one of the subcategories, interventions to improve social skills, and one example of interventions to improve social skills, which you may be able to make out here, is training in how to use digital technology. And in the columns, you have different types of outcomes. 2 outcomes that interest us most are loneliness and social isolation, but there are also several other related outcomes. And in this cell, for example, you have an indication of the amount and quality of evidence. Here you have the amount and quality of evidence that pertains to training and how to use digital technology on the outcome of social isolation. And these bubbles indicate the amount and the quality, and the green here, for example, indicates low and critically low quality reviews. So in this cell, there are quite a few reviews, but they are of low and critically low quality. In blue, you have the moderate and high quality reviews, and so forth. 4th feature I'll mention are the filters. They allow you to select subgroups of studies. For example, studies from a particular country, or studies from a particular region, or studies of a particular research design. You can, for example, decide you only want to see the randomized controls trial. So this gives you, I hope, a taste of these evidence and gap maps. Important to note that evidence and gap maps say what intervention there is. They don't tell you what the intervention says. They do not synthesize the findings of the evidence. Nonetheless, they serve a number of very useful purposes. First, they increase the discoverability and use of evidence by policymakers, by decision makers, by program commissioners, and by practitioners. Second, they help guide implementing agencies away from interventions that are unsupported by evidence and towards those interventions where there is evidence showing they work. Third, they can contribute to the production of evidence guidelines, which include recommendations and other higher level evidence synthesis products. And fourth, they help identify research gaps, areas where more research is needed, and they help guide the commissioning of research in a more coordinated, in a more strategic way. I won't show you all the findings from this evidence and gap map, but just to say this one thing, that we found in total about 200 articles, and 97 of these were systematic reviews. So these were systematic reviews on interventions to reduce social isolation and loneliness, and about 103 were primary studies. Okay, now I'll turn to the selection of the 5 priorities for addressing the abuse of older people within the decade of healthy aging. I'll describe the process we went through and give you kind of a sneak preview of these 5 priorities, which will be launched in actually on the 15th of June. They'll be launched on the 15th of June, so this will be shortly after you hear this presentation. We selected these priorities in 3 steps. First one involved the identification of some of the main challenges facing the fields, and we identified these challenges through a study of the factors that probably account for the low global priority of the abuse of older people. That was one way we did it, and the other way we did it was through an evidence and gap map on all the main aspects of the abuse of older people. I'll say more about that in a minute. In step 2, we shortlisted priorities. Step 1, we identify the kind of a long list of challenges. In step 2, we tried to shorten this, and we did this through an online survey to rank the priority of the long list of challenges we created in step 1. And then we held a meeting of experts and stakeholders to discuss this short list of priorities, and also to start generating possible solutions to address these priorities. In step 3, this was kind of the final selection of the 5 priorities, which we did by sending it out to the participants in the meeting. We put these 5 priorities in a draft document, and the participants of this meeting then commented on them, and then we produced a final version of the document tackling the abuse of older people, 5 priorities for the UN Decade of Healthy Aging. I'll say a few words about some of these steps of the process to identify these priorities for the field. We did an evidence and gap map on the abuse of older people, somewhat similar to the evidence and gap map on digital interventions for social isolation and loneliness. This evidence and gap map looked at studies on the prevalence of the abuse of older people, its consequences, risk and protective factors, and interventions to prevent, detect, and respond to abuse of older people. We had multiple partners involved in the creation of this evidence and gap map, and we included over 100 systematic reviews. It was only based on systematic reviews, and technically this is called a mega map rather than an evidence and gap map. We also did a study that investigated the factors accounting for the low global priority of elder abuse. And this has been published as a paper entitled Understanding the Factors Shaping the Global Priority of Addressing Elder Abuse. The aim of the paper was to identify the factors that account for the low global priority of elder abuse. We used a tried and tested method that's been used to identify factors accounting for the low global priority of other public health issues. And we did a systematic review of the literature, and we also interviewed 26 key informants. These are the results of this study identifying the factors accounting for the low priority of elder abuse. I won't go into detail here. It will soon be published, but basically we identified a set of factors having to do with the nature of the issue. For example, the inherent complexity of abuse of older people, a set of one factor to do with the policy environment, and a set of factors to do with the capabilities, the abilities of the proponents, the people kind of advocating, pushing for addressing the field of elder abuse. And you can see some of them here. So on the basis of this evidence and gap map and this research identifying the factors accounting for the low global priority of elder abuse, we put together a long list of 15 challenges. And then we asked 50 experts and stakeholders around the world to rank this list of priorities in an online survey. And this is just a shot of the online survey. And this is the results of the ranking of this long list by these 50 experts and stakeholders. And then we discussed them in an online meeting. And we finally ended up with these 5 priorities for the field of the abuse of older people for the decade of healthy aging. These priorities are, and I won't go into too much detail, but the document is available that elaborates on them. The first of these priorities is to combat ageism. Ageism is considered to be a major reason why the abuse of older people receives so little attention, and it's also considered to be a major risk factor for elder abuse. The second priority is to generate more and better data on the prevalence of elder abuse and on risk and protective factors to gain a better understanding of the issue and also to raise awareness of the problem. The third priority is to develop and scale up cost-effective solutions to stop the abuse of older people. This was a huge gap that was revealed by the evidence and gap map and also by the research on factors accounting for the low global priority. Was that the huge gap was that there are currently almost no interventions to respond, prevent the abuse of older people that have been shown to work in high quality interventions. So almost no solutions to this problem supported by good evidence at this point. The third priority that came out of this exercise was make an investment case focusing on how addressing the problem of abuse of older people is money well spent. And the last priority is to raise funds as more resources are needed to tackle this problem. So briefly, these are 2 examples of research and evidence synthesis activities related to these 2 cross-cutting issues of social isolation and loneliness and elder abuse that we've been engaged in this last year and a half. Thank you very much for your attention. Bye-bye.
Our third session is the platform for the decade of healthy aging, sharing knowledge and connecting stakeholders. And the speakers are Dr. Patricia Morsch and Mr. Kazuki Yamada. Dr. Patricia Morsch is from the United States. She is a physical therapist, graduate certificate in public health. She holds a Master of Arts in Gerontology from the University of North Carolina and a PhD in biomedical gerontology from the Pontificia Catholic University of the Rio Grande do Sul in Brazil. She currently serves as the Healthy Aging Advisor in the Department of Family Health Promotion and Life Course at PAHO headquarters in Washington, D.C., the regional WHO office for the Americas. Mr. Kazuki Yamada is a technical officer for the Demographic Change and Healthy Aging Unit at the World Health Organization. He supports the implementation of the Decade of Healthy Aging through management of its communications and the knowledge exchange platform at www.decadeofhealthyaging.org. Kazuki holds over 10 years of experience in communications and digital connectivity and is a social gerontologist and medical scientist by background. The floor is yours.
Good morning, good afternoon, good evening to all. My name is Kazuki Yamada, Technical Officer with the Demographic Change and Health Aging Unit at WHO in Geneva, Switzerland, and it's a real privilege to be speaking at the 22nd World Congress of Gerontology and Geriatrics. I'm also truly delighted to be speaking at the symposium, not only with my colleagues Vivian from the Campo Collaboration and with Jyotis and Chris from WHO, but also with my co-presenter today, Patricia from the Pan American Health Organization. Today's symposium is focusing on data, research, evidence, and knowledge for the UN Decade of Healthy Aging. My colleagues have touched upon the first three so far, and now Patricia and I would like to delve into the fourth, knowledge for healthy aging. But why knowledge? From an information science perspective, the notion of knowledge has always encountered a little bit of difficulty with pinning down a precise definition. But colleagues familiar with this field will also be familiar with the so-called information hierarchy pyramid, or the DIKW pyramid, which itself has been subject to a lot of contention and remarkably endless discussion. But for the purposes of today's discussion and opening it up, let's start with this construct and open up the discussion from there. If we map data, research, evidence, and knowledge within this hierarchy, roughly speaking, it might end up looking something like this. Data are the raw symbols, signs, and signals, which are the products of our observation. When we contextualize data by introducing connections or a structure to give it relevance for a purpose, we create information. Now, if we take knowledge as information that has been taken a step further by imbuing it with a particular truth-claiming quality, that is to say, when we say we know something, we're not only saying something about a set of data that has context, information, but we're also asserting a belief in that context's truth. We may be able to say that evidence seeking and research, therefore, might be the processes by which information or even data is translated into knowledge. Now, the precise area, so where research is and where evidence is as processes between data, information, knowledge are debatable. But I think it's clear that these are processes that transform one form of data, information, knowledge into another. So what's the point of saying all of this? The UN Decade of Healthy Aging, when it was adopted by the World Health Assembly and declared by the UN General Assembly in 2020, was a call to collaborate towards catalyzing action. The message is, we need to work together now, because to truly leave no one behind by 2030, we need to act together urgently to create a world where all people can live long and healthy lives. What do we need for this collaborative action? First, we need knowledge about who is out there and what they're doing in the field of aging. And beyond, we cannot connect with others without knowing who these people are and what they're doing. But second, we also need to exchange the knowledge that we've produced within our respective areas and fields and share it with the global community to ensure that we all have as much access as possible to what may potentially work, thereby informing action, in making the transformations needed to achieve success during the UN Decade of Healthy Aging. By sharing knowledge, we can also count on each other to verify our assumptions as what we take as the truth, to ensure that the knowledge we act on truly has the potential to improve the lives of older people, their families, and communities. To date, the knowledge production and sharing activities that we see in the field of aging, and perhaps beyond, are fragmented, dependent on specialist knowledge for access, and are even characterized by deep privilege and power imbalances in who gets access to which knowledge and which stakeholders. Think about public health and medicine. Is the knowledge that you're producing reaching the stakeholders within your field that need to be reached to generate action? And let alone, are you reaching the stakeholders outside the field, like policymakers, that can also benefit from that knowledge? Under the collaborative call of the decade, this can no longer continue. And member states also recognize this, which is why the Decade Plan of Action calls for the establishment of a decade platform that supports implementation of the decade through knowledge sharing and acting as a convening mechanism for stakeholders. The purpose of the Decade platform is to support everyone in harnessing and accessing the knowledge they need to foster healthy aging in the most relevant, democratic, open, and inclusive way possible. To this end, the Decade platform supports knowledge exchange across a wide range of knowledge types in English, French, and Spanish, and anyone can share what they know to any of the available categories in the platform at any time for free, which are reviewed for safety and relevance by a team of volunteers before publication. We hope you'll take the time to explore the platform, as that is the best way to get a sense of what is possible through it. But for now, I'd like to pass the floor to Patricia, who will talk a little bit about the platform and collaborative knowledge exchange from the perspective of regional implementation of the Decade.
Thank you, Kazuki. Hello, everyone. Thank you very much to the IAGG for the opportunity to participate today in this important event and share this perspective on the Decade of Healthy Aging platform. It is a pleasure to be sharing this symposium with Kazuki and my colleagues from WHO headquarters. To inspire engagement on the platform, I would like to give some insights on the region of the Americas in the context of the Decade of Healthy Aging and perspectives on information, data, and knowledge sharing. Next one, Kazuki. So the Decade of Healthy Aging is by its nature a collaborative movement based on connecting and convening stakeholders who work on the 4 action areas at the Decade at the local level and those seeking information, guidance, and capacity building. The aging process, as well as the aging of populations, is different in different countries and very unique. Let's take the region of the Americas as an example. Canada and the US are already considered old because approximately 21% of their population is at least 60 years of age. In these countries, the aging of population has taken place gradually over the period of around 50 years. In contrast, in Latin America and the Caribbean, the growth of the aging of population will occur in a severely contracted interval of 20 to 30 years. And I would like to highlight the differences within the region, as currently people over 60 comprise about 30% of the population in the Caribbean, 12% of the population in South America, and 9% of the population in Central America. These differences are also seen in other areas of the world. Therefore, considering a global movement such as the Decade of Healthy Aging, it is very important to engage as many stakeholders as possible to provide evidence and knowledge sharing on the most variable experiences that can address the different needs from countries, regions, as well as from older populations. Experiences previously tested and applied in one location can serve to another to be replicated or give inspiration and be adapted in another place with different reality. Next one, Kazuki. As I mentioned, the region of the Americas has a very diverse aging process, but it is one of the regions that has been experiencing one of the fastest aging populations worldwide. And this fact requires action. However, not only the aging process in the Americas is diverse, the region is marked by diversity on its cultures, languages, socioeconomic status, and levels of inequity. Therefore, when planning actions, it is very important to be able to have content and context-oriented knowledge and connections that can impulse the work at the local level, considering different priorities. The Decade of Healthy Aging baseline report states that 3/4 of the world's countries have limited or no comparable data on healthy aging or on older age groups. And this situation contributes to the invisibility and exclusion of older people. As you can see on these graphs, 15 countries in the region of the Americas have cross-sectional national data on older adults, and only 10 countries reported having such longitudinal studies. Although there was an increase on the development of such studies from the last report, during the decade, partners are requested to support research and innovation and gather evidence on what can be done to foster healthy aging in different contexts. In the Americas, it is common to find information and studies in some specific countries and very little in others. Knowledge sharing and connections is crucial, especially in countries with less resources to innovate and be able to improve. Next one. The Decade of Healthy Aging Baseline Report also presents a pathway to healthy aging, aiming to accelerate action during the decade. This approach is needed to support priorities and motivate action. Many of these actions depend on information and evidence that applies directly to older persons and information gathering to be able to monitor and evaluate results as well as share evaluated experience to favor learning across communities and countries. The platform is a great mechanism to enable dialogue and translation of knowledge and experiences within the region and broadly. Next one. We are encouraging countries to fully participate on the platform to show experiences that are already in course to support healthy aging and others that are being planned along the decade. We are working closely with member states and with our colleagues from WHO to have the platform providing knowledge and connections that can support the implementation of the decade at the local level. And we would like now to show some examples of opportunities that are published on the platform. Kazuki.
Thanks so much, Patricia. So really quickly, I just want to give you one example of one initiative we ran on the platform in English, French, and Spanish. As some of you may know, one of the action areas of the UN Decade of Healthy Aging is combating ageism, changing how we think, feel, and act towards age and aging. And as a part of that, with the release of the Global Report on Ageism, the UN Global Report on Ageism in March of 2021, we also launched a global campaign to combat ageism, which is a movement that everyone can join to really combat ageism, as the name says. But to build a movement, we need to bring people together. We need to learn what other people are doing to combat ageism, and we need to make sure that we are collaborating so that we can change the narrative around age and aging. So we ran this initiative called Ageism Through the Ages on the platform, which is really a mechanism for us to, call for what are people doing on ageism? Who are the change agents on combating ageism? And can we use the platform to gather them all in one place so that everyone knows who is working in this space? How can I work together with others? What has already been done? And what are the lessons learned from those practices so we can build on them so that our movement to combat ageism can grow stronger and stronger as the decade progresses. And so we have this on the platform. It's in English, French, and Spanish. We ran it from the 1st of October, which is the Day of Older Persons, the UN International Day, and until 20 November, which is the International Day for Children. And we ran this, and if you want to learn more about it, you can visit on the platform under topics and initiatives, other initiatives, ageism through the ages. But now I want to pass on to Patricia for the second example.
Thank you, Kazuki. Well, continuing with another example that is also available in English, Spanish, and French, I would like to mention the Healthy Aging 50. Although the Decade of Healthy Aging has recently started, we know that there are already many actors all over the world acting like leaders, working to transform a world into a better place to grow older. Across government, civil society, academia, business, the media, local communities, these leaders are pioneers in what they do and how they do it. So the Healthy Aging 50 seeks to recognize the contribution of 50 leaders around the world to showcase their work as inspirational examples on what individuals are already doing to make the Decade of Healthy Aging goals a reality. I would like to highlight some examples of actions that you might consider. Innovative ways to promote healthy aging and knowledge on healthy aging, such as data collection, ways to favor engagement of different sectors to work with healthy aging, actions to improve capacity building, and strategies that engage older people, their families, and communities, ensuring that their views inform every step of the design and delivery of activities. We want to showcase leaders in all the different areas and sectors, as well as from different countries and realities. As we mentioned earlier, The inclusion of a variety of contexts can expand our work and ability to replicate good practices. All selected leaders and their outstanding work will be available at the platform to favor connections and knowledge sharing. So we would like to encourage you to participate on this movement. You can nominate yourself or anybody else you know who develop an important work to improve life of other people. You'll find more information at the platform.
Great. And just to quickly wrap up, Patricia, go ahead.
So to continue working together throughout the UN Decade of Healthy Aging, the exchange of knowledge and the building of new connections and collaborations through this act will continue to be crucial for the ultimate objective of inspiring transformative actions that improve the lives of other people, their families, and their communities. So we hope you take the time to join us at the platform, as well as spread the word about it, to leverage this unique opportunity to work towards a world where all people can live long and healthy lives.
And after explore the platform, we hope you'll also take the time to contribute your own knowledge and expertise in the space through our submission form. And we also have a number of knowledge initiatives, as Patricia mentioned, running on the platform in English, French, and Spanish. So we hope you'll join us there and get involved in the decade to create a world where all people can live long, healthy lives. Thanks very much.
Thank you.
Thank you again for joining this session. And we hope to continue to see you throughout the decade of healthy aging as we build the evidence for impact.
Hi, everyone. Thank you very much for joining our session related to evidence, data, and knowledge around the decade of healthy aging. I would like to highlight some important topics concerning the information presented by my colleagues from WHO. Data, it's crucial to be able to implement strategies and to work based on the needs and on effective interventions. Therefore, it's very important to call attention that data, information, and knowledge sharing is one of the enablers of the decade of healthy aging. So a part of having the 4 action areas, the Decade Plan of Action also has 4 main enablers, which are crucial strategies that will favor the work and effective work on the 4 areas of action. And of course, as I mentioned, data is one of them, together with connections, knowledge sharing, strengthening capacities and leadership, and of course, engagement of other people, because we have to understand what are their needs, what are their priorities to be able to move forward with actions that actually make sense for the population we are working for. I would like to highlight that on the current work developed by WHO, some of it is already available on the baseline report of the Decade of Healthy Aging, that is gonna be reported gradually on the 10 years of the decade. So the first report on intrinsic capacity data, functional ability, and stating where we are, it's available and it was published in 2020. And the next reporting will be on 2023 based on the information that my colleague Jotis presented. Also, as my colleague Chris Micton mentioned, there is this work on social and loneliness, and unfortunately he couldn't be here to present today and to answer the questions that that I'm seeing on the chat right now. And exactly because of the lack of data that we have and the difficulty on reporting and working on social isolation and all the and including AJs, as we saw, we have the report now, but there is a huge data gap. So WHO is starting the prioritization, research to be able to move forward with the specific actions. And of course, it's very difficult to implement in some studies, but with some collaborating centers that Dr. Micton mentioned on his presentation, we are trying to strengthen even more the work on these areas. Also, I would like to encourage you all to visit the Decade, the platform, to share your research or projects and to connect with other people that have similar interests. Maybe this is a way to strengthen the work, to develop in different places, realities, and understand a little bit more about aging in different scenarios. And of course, again, invite everybody to participate on the Healthy Aging 50 and nominate people, leaders, yourself, everybody that has been doing a great work on healthy aging. I'm gonna see the comments on the chat to see if we have something else that I can by myself respond. So my colleague Nora Keating is saying that there is the data gaps across countries within the regions of the Americas. So to what extent the platform can motivate the development of such data and within these countries that are visible. So this is the goal with the platform. We know that a lot of information is not readily available because it's not open access. Maybe sometimes it's not readable for policymakers, or understandable for policymakers or people that are working on the field. So being able to use the platform to translate and share the data and share projects that are being done is our goal. Right now on the platform, a group of specialists were created that are going to support worldwide the data that is available and information that is available on the platform. And we are hoping with the work of this group, we have even more engagement and more information readily available. So we do have a comment from Flores Castillo about congratulating on the submissions on the Healthy Aging 50, and if there is a possibility of registering independent actions to promote healthy aging, or are only institutional initiatives accepted. Yes, all the information, even individual information and work is possible, and people can register themselves as people interested and people working on healthy aging, and register as well their work, and they can also register their organization, their institution. So there is this different areas on the platform that you can register as a person or as an organization, and as well as there is a space for older people to be engaging on the platform and to be sharing their stories, their ideas, information, and engaging on the movement as well. So I don't see any comments right now anymore. I hope the session was informative, and I hope you can all engage on the platform and on the movement of the Decade of Healthy Aging. Thank you very much for joining, and I hope you enjoy all the sessions of the IAGG Congress. Thank you very much.